The Endpoints of Resuscitation, a modern perspective. Welcome to the Everything Surgery podcast, where today we delve into a pivotal topic in the world of critical care, the endpoints of resuscitation. This conversation moves beyond the traditional approach of administering fluids and simply monitoring blood pressure. Instead, our focus is on determining the moment when the primary objective, restoring adequate tissue perfusion and oxygen delivery to prevent cellular injury and organ failure, has truly been accomplished. Modern medicine has evolved in its understanding of resuscitation. Historically, the emphasis was placed on microcirculatory markers such as blood pressure. However, we now recognize that achieving normal blood pressure does not necessarily guarantee adequate oxygen delivery at the cellular level. The focus has shifted toward microcirculatory and metabolic targets, which more accurately reflect the patient's physiological status. To provide structure to our discussion, let us categorize the endpoints of resuscitation into three progressive tiers: clinical and hemodynamic, metabolic, and tissue perfusion or oxygenation. Each tier offers distinct insights into the patient's response to therapy and guides us toward the ultimate goal: reversal of cellular shock and prevention of organ failure. From stable vitals to adequate perfusion. Historically, a normal heart rate and blood pressure were considered sufficient indicators of successful resuscitation. However, contemporary evidence demonstrates that these parameters can be misleading. The human body is remarkably adept at compensating for shock, sometimes until the late stages of illness. The ideal endpoints are those that directly reflect the state of microcirculation and cellular metabolism, offering a more nuanced and accurate assessment of patient recovery. Tier 1. Clinical and hemodynamic endpoints. The big picture. We begin with the initial, readily available clinical markers. While these are necessary, they are not sufficient on their own to declare resuscitation complete. Restoration of normal vital signs. A decreasing heart rate trending toward a normal range is an encouraging sign, yet persistent tachycardia may reveal ongoing stress, pain, low blood volume, or continued compensation. Blood pressure stabilization, particularly maintaining a mean arterial pressure above 65 mm of mercury, is considered the minimum required for autoregulation of vital organ blood flow. Some patients, such as those with chronic hypertension, may require a higher target. Normalization of respiratory rate, signaling resolution of metabolic acidosis and improved gas exchange, is another key parameter. Improved clinical perfusion. Mental status is a straightforward yet powerful tool. Improvement in alertness and cognition signifies better cerebral perfusion. Conversely, confusion or lethargy may indicate ongoing hypoperfusion. Skin assessment provides additional insight. Capillary refill time less than 2 seconds and warm, dry, normally colored extremities suggest restored peripheral circulation. Adequate urine output, producing more than half a milliliter per kilogram per hour, is a direct reflection of renal perfusion and is among the most reliable real-time indicators of adequate intravascular volume and cardiac output. Tier 2. Metabolic and oxygen transport endpoints. The cellular level. This tier is the gold standard in modern resuscitation, as it directly evaluates whether oxygen delivery adequately meets tissue demand. Lactate clearance. Lactate is produced during anaerobic metabolism. An elevated lactate level, generally above 2 millimoles per liter, indicates tissue hypoperfusion. The focus should not be on a single normal value, but on a trend of decreasing lactate. Ideally, a reduction of 10 to 20% per hour or normalization within 6 to 8 hours. Persistently high or increasing lactate is a marker of ongoing shock, even if other vital signs appear normal. Normalization of base deficit. Base deficit, determined from arterial blood gas analysis, serves as a surrogate for metabolic acidosis stemming from lactic acid and other acids. A trend toward a normal base deficit, typically between -2 and +2 milliequivalents per liter, indicates resolution of acidosis. Central venous oxygen saturation or mixed venous oxygen saturation. These measurements reflect the oxygen saturation of blood returning to the heart after tissue extraction. They indicate the balance between oxygen delivery and consumption. Achieving and maintaining a central venous oxygen saturation above 70% is a major target and has been integral to early goal-directed therapy for conditions such as sepsis. Tier 3. Advanced and dynamic endpoints. Fine-tuning the response for patients in intensive care or those not responding to initial interventions. Advanced parameters help optimize cardiac performance and minimize the risk of fluid overload. Dynamic indices of fluid responsiveness. These metrics predict whether a patient will benefit from additional fluids by increasing their stroke volume or cardiac output. Administering fluid to a patient who is not responsive presents the risk of pulmonary edema without improving perfusion. Key parameters include stroke volume variation and pulse pressure variation. Values above 12 to 15% suggest fluid responsiveness in appropriately selected patients. The passive leg raise test, which is a reversible fluid challenge, is also used. An increase in stroke volume or cardiac output of more than 10 to 15% following a passive leg raise indicates ongoing fluid responsiveness. Adequate cardiac output and cardiac index. Direct measurement of the heart's pumping ability is critical in complex scenarios. A cardiac index above 2.5 to 3 liters per minute per square meter is often targeted, though the optimal value may vary based on individual patient needs. Summary. The composite endpoint of resuscitation. It is important to acknowledge that no single measurement is perfect. The true endpoint of resuscitation is a composite of these goals being met: normalization of vital signs, confirmation of adequate tissue perfusion, and reversal of cellular shock. The modern approach places special emphasis on lactate clearance and tissue perfusion indicators, while integrating dynamic assessments to guide therapy and avoid the adverse effects of over-resuscitation. Clinical pitfalls and the concept of enough. There are important caveats to consider. A patient may present with normal blood pressure as a result of intense vasoconstriction, yet still suffer from profound hypoperfusion, as seen in compensated shock. Elevated lactate can result from causes other than hypoperfusion, such as liver disease, seizures, or certain medications. The trend, rather than isolated values, is key. Perhaps the greatest pitfall is continuing aggressive fluid therapy once all endpoints are achieved. This can lead to fluid overload, tissue edema, impaired oxygen delivery, and worse outcomes, especially in cases of acute respiratory distress syndrome and heart failure. Recognizing when to transition from resuscitation to fluid management is essential. Conclusion. To conclude, the endpoints of resuscitation encompass a multidimensional set of goals, advancing from the normalization of vital signs to the assurance of cellular recovery. The contemporary approach prioritizes lactate clearance and tissue perfusion metrics above blood pressure alone, and employs dynamic, individualized assessment to guide intervention and prevent the harms of over-resuscitation. Thank you for joining us on this episode of the Everything Surgery podcast. If you appreciate our content, please like, share, and subscribe for more insights into the art and science of surgical care.